Hi, Monty Pal here on behalf of GU Oncology Now. Today we're going to be talking about updates in kidney cancer with three of my dear friends. We're going to start with a quick round of introductions, beginning with you, Cristina.
Hi, I'm Cristina Suárez. I'm a medical oncologist at Vall Hospital in Barcelona, Spain.
Dan.
Hi folks, Dan George from Duke. I'm a GU medical oncologist and happy to be part of the panel.
Awesome. Brad.
Yeah, and I'm Brad McGregor, also a GU medical oncologist from Dana-Farber in Boston.
Awesome. All different parts of the world here. Monty Pal from Los Angeles, California, and we're going to dive right in. So we talked about good risk disease, we talked about intermediate risk disease and poor risk disease. Now let's dissect further the TKI-IO questions. So, amongst the three options that we use in this category, Len-Pembro, Cabo-Nivo, Axi-Pembro, I'd say those are the three most prominent options. What are you typically leading on? Dan, maybe I'll start with you there.
Sure. The truth is I think we got three really good options. So I don't feel like, gosh, there's one drug you got to do. I've used all three of these and I've been satisfied, with all three of these and how they can work. But they are different, and I will say, I probably, the Cabo option I like because I'm not given the full dose. I feel like starting at 40 milligrams, I'm starting closer to a dose they can tolerate longer term. And many of my patients don't need a dose reduction. But if they do, I still have 2 dose reductions to go to. And, it gives me that kind of flexibility. So I have a lot of experience with that and been very satisfied. Axi's been around the longest, Pembro Axi, and I like that regimen a lot. The flexibility of going to every 6-week dosing with the Pembro is really nice for our patients, particularly those that come a long distance. The Axi is particularly nice in patients where I'm worried about the reversibility of toxicity. So if they get a significant diarrhea or issue, I can shut that down and it's going to get better quicker. It helps me actually differentiate sometimes mechanistically what might be driving some of those toxicities. So that one has some advantages, but it does have a little bit of more up and down PKs. So, hypertension might be a little bit harder to kind of find that middle ground on. And so those are some of the experience I've had. Len-Pem has been the newest regimen out there, and I've been particularly impressed with the responsiveness in that regimen. It is a pretty high dose to start with, but I have patients that can tolerate that. Surprisingly, it seems to be better tolerated than our experiences with Len-Eve in the very refractory setting. But it still thinks it's something that requires close monitoring and management to get that individual dosing right. So I think they all have their strengths and weaknesses. I've used them all, and I think I kind of individualized those different, characteristics of the drugs in choosing which regimen I'm going to use for each patient.
Interesting. So you sort of individualize your approach. I tend to be a little bit more dogmatic. I tend to use a lot more Cabo-Nivo, in the upfront setting. I've really found that approach that you highlighted so beautifully, with Cabo is a risky maneuver, right? Going from the 60 milligram dose that we're used to using in the salvage setting, decreasing it to 40 in the frontline setting. But it really, worked beautifully with hazard ratios for PFS that are comparable to the other frontline trials, overall survival hazard ratio that's identical. We do see some quality of life benefit there as well, with a regimen as compared to some of the others that we've explored in the frontline setting. So that tends to be my approach. Brad, tell us about your approach amongst these TKI-IO regimens.
Yeah, I agree. I think they're all great options. It's really a matter of being comfortable with dosing. And I think the key thing when I talk to a patient about whatever TKI-IO combination is, hey, we're going to start at whatever dose, but it's okay if we dose reduce. I tell them at the very beginning, so they don't get worried when they come in 2 weeks. I'm like, listen, you're having really bad side effects, you should reduce that dose. I mean, in the trials, majority of the patients did dose reduce, and we saw these impressive results. So I'm very quick, even with Cabo 40, over half patients reduce the dose, and that's okay. I tell them, we're going to start this dose. If we have to go down, expect that. We start at Len 20, we'll see you, and it's okay to go down.
Brad, do you ever start at a lower dose?
I don't. I think there's something with you need to have that initial high dose intensity. So I tell patients, listen, we're going to start high. We think there's a benefit to starting the highest dose that you can tolerate. We know if we have to reduce the dose for toxicities, we're not going to be compromising efficacy. That was done in the trial, and patients do well with that approach. I worry if you start low and the patient feels well, they don't want to go up, and you don't know. Maybe they could have tolerated the higher dose and have a better response, right?
I think that's exactly right.
I tend to start high.
Yeah.
I start high, and but I counsel them very early on. It's okay to dose reduce. To your point, I think the Cabo-Nivo data is appealing. It starts with that little bit, that lower dose of Cabo, impressive results, and we saw at just this meeting that hazard stay the same. That median overall survival now is close to 50 months with extended follow-up, which is which is impressive. I mean, that's really a marked difference from what we saw before. So I think, hope that there may be a tail to the curve with some of these TKI-IO combinations with extended follow-up. You know, Nivolumab was the first to be done, but now hopefully with the TKIs, we see those extended follow-up and be great.
Absolutely. Christina, what about you? Amongst these TKI-IO regimens, can you pick one amongst the three?
So I agree with everything that you have commented. And we have a complicated situation in my country since we don't have available them. And all my experience come from the clinical trials that I have many patients in all these clinical trials. And I cannot choose one or the other. At the end of the day, they have the same adverse events, but in different, for example, different frequency. But at the end of the day, you know how to manage. We have been using TKIs for so many years that I'm not afraid about managing the toxicity. So I think it's difficult to choose from one or the other. I would start with the full dose, that's for sure, because some patients will need the full dose, and if I need to reduce the dose, it's okay. But it's difficult to, and going back to the patient that we were talking before, like symptomatic patients, or then I would choose or Nivolumab or Lempem, because the PD rate is just 5% instead of 10% with Axi-Pembro. But apart from that, it's difficult to choose one or the other.
I agree. I mean, like the Lempembro is damper. I mean, that every 6-week dosing of Pembro is pretty nice. When patients have to drive into Boston and pay like however much money, they have to pay for parking, and they don't have to do that every 6 weeks or once they get on a standard dose. I mean, that's a great benefit to our patients. And I think, again, starting with that 20 of Len dose, some patients can tolerate it really, really well. And if they can't, you just be quick to dose reduce, and I think it's highly effective.
And I think to Monty's point, I mean, I think if you're not treating kidney cancer like every week, that's not like the thing you do like with us. I think, having a regimen you're comfortable with, that your nurses are comfortable with, and your staff and everything, and just kind of sticking with that, you're not really going to go wrong here either. So I think, the message out there is I think, they're all reasonable options and good options, really, for your patients. But they do have differences, and, if one of these differences really makes a separation for you for that particular patient, great. But otherwise, it's okay to kind of treat patients the same with what you're comfortable with.
Yeah, and at the end, I think that what is very important is like you monitor the patient very closely at the beginning. So then it's difficult.
Really kind of tight monitoring up front, hone in on the right dose for the patient.